Dear Tilo, dear Fiona, dear Gustavo, it's a privilege to have me here. My disclosures. I'm here to talking about the G-branch. G-branch device is customized three-branched device developed by Professor Gu from Peking in China, the General Hospital. So far, as I knew from the company, that there have been 95, more than 95 implantations, maybe more than 100 or more or less successful implantations in China. And we have the privilege to be the first worldwide outside of China to use this device as customized device. So here are some features of the graft. It's about two inner branches preloaded for the SMA and the celiac trunk, and two outer renal branch, as you can see. And here are some product informations, what is very important for me. Like you can see here, the total length of the device, which means the maximum length of the U-branch device would be 15 centimeter, which is very interesting aspect in my opinion, to cover more or less of the descending out the supraceliac, and to have maybe to reduce the risk of spinal ischemia. Much more attractive aspect, in my opinion, for this graft to having this configurations of marker. You can see the marker as very visible. You know the inlet, but the inlet, but the outlet of U-branch, they are ring shaped. That's why it's my opinion very nice technical aspect to have, and I will show you some pictures. Further to the technical benefits of this device, you have this semi-release mechanisms. Also, you can see here. So you just partially release your device just below to the branches, and you still have some room outside of the branches and the anatomies, and you can cannulate the branches and get to your target vessel, and later on you can release the distal part later on. So high flexibility of the system. You can see here some complicated cases from Professor Gu. We had a lot of preparations of the implantations. I traveled to China. I met Mr. Gu. It's a very nice guy, actually, and unfortunately he's not today in London. And we had a lot of meetings, a lot of Zooms, a lot of the training for prototype systems. And we had the first implantation in Europe in June last year successfully in my center. You can see here the CT scan of this patients with 8.5 centimeter suprarenal or juxtarenal aneurysms. You can see here some fluoroscopy intraoperative example to cannulation of the right renal branch, right renal, also deployment of VBX and final angiogram. Here you can see the 3D postoperative reconstruction of these patients. Here also a for discharge, happy patient with happy surgeons, and we have so far of this first patient 10-month follow-up. So we became, after case, more brave, and we tried this system also for very complicated anatomy, like you see, with very kinked rhinovisceral segment, and we were convinced of the ability of this system. So here also, for example, I brought for you some intraoperative fluoroscopy, like this example. You can see we would be able to accommodate the 4 branches within 40 minutes, which means about 10 minutes for cannulation, bridging stent, selective angiogram, which means actually more quicker of operation time. So my personal experience so far for 10 patients, we select the patients. Actually, most of the patients were with very nice anatomy. That's why we have so far very positive outcomes. I cooperate with Mr. Gu. We exchange the experience. I have already experience with other systems which are available here in Europe. That's why it's very, very interesting exchange with China, and we evaluate to share the data, but also to have a German or European perspective multi-center study. So as conclusions, ladies and gentlemen, is for me very interesting device. I do think that we need new technologies for this kind of complicated procedures. Is easy to implant, much easy compared to the system that I have know so far, and has potential to create more range of anatomies and to become, why not, off the shelf device. The data has to be published, and we do need robust data from China firstly, and maybe from Hamburg in the future. Thank you very much.
Thank you, Marwan, for sharing this very early experience, and it's open for discussion. If somebody wants to come to the microphones, ask some questions. I'm certainly interested to
everybody is leaving now and tired after this long way.
Yeah. I'm certainly interested to understand what is the sweet spot for this device design. Where do you see that, more in the juxtarenal area, or is this for thoracoabdominal aneurysms? Or
thank you for the question, Thilo. I think the device is very smart designed also for the juxtarenal. And we had recently saw paper of using, we still use the branch device for actually thoracoabdominal, and you have the length of this device at least 20 centimeter. I mean, I'm talking about the available systems which we have in Europe. There are two manufacture two systems, and we still use them as off-the-shelf devices. We have one off-the-shelf device, the other also. I'm talking about T-branch and inside. So. And comparing to this system, the design of the system with two inner and two outer, which may fit also more the suprarenal, and the length of the device is maximum 15, which means I have at least less coverage of the supraceliac or the descending aorta. That's why I see very great potential for the juxtarenal or suprarenal pathologies.
Youssef, the device is tapering very broadly to the distal part. So how narrow is the distal part, and what is like the distal options you have with the device?
The distal part of the prosthesis of the stent graft.
Yeah.
It's still customized, but I saw paper from Gu, from the developer. It has been published like 5 weeks ago in the European journal as of the shelf. However, the distal part you can get it designed from 14 to 18 millimeter, which still less than the systems which we know. I thought because maybe the patients in China, they are not big comparing with the people or the patients in Europe or in Denmark or the north of Germany. However, the branches which we get from China, the first were 10. Like more that we know, and it took sometimes actually a lot of months to get the guys of R&D to get branches which I know like 8866, and I think it depends on the system over there. They have all their own Chinese bridging system. They have tapered, some kind of tapered bridging system.
Would you see it as an advantage, this very small, this tapering or the diameter, the small diameter, to go for monoiliac in special conditions if you would need it? Is there like anything?
Not really, because I see that this could be beneficial for this kinked anatomies, but to go to monoiliac, I wouldn't do it for standard cases. You don't need to. But actually, the 10 cases we use, either 16 or 18 of the distal part. And just actually, we don't have any EVA system available from this company. That's why we use the system which we do use for other branch devices. Actually, only bodies which we use other cases.
Thank you. And any further questions? If not, Marwan, we understand it is on a CMD basis currently, but there's probably the goal of having it CE certified, so we will see that in the future. We certainly will have you back here. Thank you very much.
Thank you too.